So what we'll do today, we're just going to look at some of the morning. We're going to look at some of the X-ray types that we see, and we're just going to kind of revise. Am I going to be in the way? Okay. So let's start. You can just close the door. Okay, and welcome to the people on Zoom as well. All right. So today we're going to analyze some fractures. All right. So what we were covering last week was that we need to follow the lines. So the lines that we talk about are the anterior, middle, and posterior line, which I'll show you guys. Don't worry. All right. The next thing that you need to decide is this a stable or unstable fracture? Okay. And which means, do I need to immobilize the neck? Now, in an emergency department, as I put there, 99.99999% of the time, you should immobilize the neck because you don't have all the investigation. You're still doing your X-rays, you're still doing your CTs, you haven't got the full range of information. So you should immobilize the neck when you suspect any type of C-spine injury. Right? Do I need extra investigation such as CT scans, MRIs, if they're available? You need to ask yourself, is my patient in neurogenic shock? All right. So just for those of you who want with us, what is neurogenic shock? What do you think it is? What happens during neurogenic shock? So your patient presents with low BPs, all right? That's where the patient's going into shock. So with the low BPs, they are unable to perfuse their kidneys, unable to perfuse their lungs, unable to perfuse their heart. But why does this happen in C-spine injuries? Any idea? Very good, exactly. So exactly what he says, all right? So to put it simply, you basically, your blood vessels are unable to contract and dilate. So they remain dilated. So all the blood basically pools in a big pool, and it's unable to, what you would call it, increase your blood pressure because it's sitting in a huge pool instead of sitting in these constricted vessels, all right? Have I mapped out the neurological deficit? So sometimes we have certain deficits. For example, one side may be paralyzed, or you may have loss of touch sensation, loss of cold sensation, loss of vibration. You know? So you get all these different types. So you need to know that. Do I have the number for the orthopedic on call, right? Because they need to be involved immediately, all right? And have I excluded other associated injuries? So the thing is, the wonderful thing about how our bodies are built, things that are delicate or things that can prove fatal if injured are generally well protected. For example, your heart. Your heart is not sitting on your palm. It's sitting behind a big sternal bone. You know, it's got a pericardium. You know, your lungs are protected behind ribs. Your skull protects your brain. But your fingers are just out there, you know. So the reason for that is, if it's important, it's protected. And the same thing applies to your C-spine. Your C-spine is actually relatively well protected if you look at it. Your L-spine, yeah, as well. Your T-spine also. So the reason when we say it's well protected, it's got this lovely corset of muscles that sit around it, you know. So they are there to actually provide support, provide protection. You've got your trachea, you've got your esophagus, you've got other things that sit in front of it and things like that. So it takes quite a bit of force to actually break a spine. Okay. So last week we had Dr. Wilson here. And we were asking people if they'd ever eaten a neck. And she says no. She's not vegetarian, but she's never eaten a neck. Have you guys eaten neck? Chicken neck, lamb neck, beef neck, anything? All right. It's a tough bone. It's not an easy bone to break. All right. And the human spine is quite thick as well. So in other words, to break it, that means something else might also be injured. All right. So you have to look at other associated injuries. Okay. So as compared to last week, what we're going to do is we're going to try and analyze these fractures. Right. So the first thing, just to show the guys who come this place on this side, I wore deodorant, you can come closer. All right. So when we talk about, sorry, I just want to get to this actually. So when we're talking about the three lines, right, the anterior line, posterior line, things like that, the anterior line is basically this line that follows along the front of your C-spine. Okay, so it should be a nice straight line, or the anterior of the vertebral bodies, all right? And then the middle line, which is the most important line, is this one, all right? I see we have pathology here, that's why you can see it's not okay, all right? And then the posterior line is basically along the spinous processes, all right? So you're just following along there. Now, when you learn C-spines in radiology and orthopedics, there's actually 5 lines that you look at. But as I was telling the guys last week, when you are in an emergency department, there's 2 things that you need to be: fast and accurate. And the problem is fast and accurate don't go well together. Generally, if you want to be accurate, you have to be slow. And generally, if you want to be fast, you can't be accurate, you know? So we have to develop ways to be fast and accurate. So we just look at the 3 lines, right? The next thing when assessing a C-spine, you have to make sure you can see the entire C-spine. So that means you need to be able to see C1, all right? So that's C1 over there. What's C1 called? Anybody remember? Atlas, very good. Anybody knows what it looks like? Nope. That's C2. So that's what C1 looks like, all right? Yeah, this is C2, all right? So any idea what C2 looks like? Just what you described, all right? So imagine a donut with an erection. Okay, and that's basically what it looks like, all right? So you'll never forget that. Nice little donut walking around with a bone. That's what C2 looks like, okay? All right, and then you need to be able to see C3, C4, C5, C6, and C7 at least, okay? So when you're looking, that's what you should be able to see. Now what happens if you can't see C7 or C6? Then that means you need to ask for a swimmer's view, okay? Why I'm saying that is a lot of people just automatically put swimmer's view. You first need to see your normal X-rays, only if it's inadequate. And most of the time, the radiographers themselves will automatically do it. You can't see C7, all right? So you need to be able to see all of those, okay? And if you suspect injuries around C1 and C2, then you do an open mouth view, okay? Now, if you want to see that, just look at last week's lecture and we cover all of that, all right? So let's try it now, okay? So we've got one now, we've got pathology. So let's have a look and see what's going on. So we'll just use this as the pointer. So we follow along our anterior line, okay? And what do you notice? As soon as you come, let's say in this area here, you can see its disruption, okay? Quite easily, you can see that there's a disruption over there, right? And when you come along the middle line, you can actually see the vertebrae themselves actually form a nice solid line, you know, when they're following along the post. You know what happens here? Not only disrupted, it almost looks like it's crushed completely, you know? And then it suddenly comes back here, all right? And then when you follow along the spinous process, which also forms sort of like a solid line, you can also see that there's an injury over here, all right? So the first thing is, which vertebra are we looking at? C1, C2, C3, C4, C5, all right? So actually this is an inadequate X-ray, sorry. We can't see C7 properly, so you'd want to do a swimmer's view, okay? All right, now looking at these, all right, just as a matter of revision, when your middle line is out of place, those are generally your most dangerous, okay? Doesn't mean the others are not dangerous. It just means you need to be extremely careful because remember your spinal cord sits behind them, all right? So when the middle line is disrupted, that's when you have your greatest chance of transection, injury, hematoma, formation on the spine, okay? Thereafter is the anterior line, okay? And lastly is the posterior, okay? But again, if you watch last week's one, then you catch up to all of them, okay? So looking at this patient, even if you don't know the diagnosis, are you worried? What are you going to do for this patient? What do you think? I mean, if we see this patient, even if you're looking at this is a patient with an ET tube, this patient's got an NGT, this patient's been through quite a bit of trauma, all right? Okay, so you can see how they were worried about this patient. So you need to phone orthopedics at 2 in the morning, right? You have to phone Small Zulu, all right? Who had a bad day already, doesn't want to come to see patients. Agreed? You'll have all worked with him, isn't it? So he doesn't want to see patients in any case. Now you have to phone him and tell him, I got a patient with a C5 fracture. All right. Now what do you have to tell him? Because you can't just tell him about a patient with C5 fracture. That means nothing, you know, because C5 fracture could be there, it could be a little teardrop, it could be something like that. Right? So you need to be able to describe what you see. So what are you seeing over here? Number one, what's happening to the vertebral body? Is it continuous? Is it non-continuous? It's avulsed, very good. So you can see an avulsion over there, right, of C5. So already you're speaking his language. So when you say avulsion at 3 in the morning, he went from to yeah. Already he wakes up a little bit. He's still not convinced, but okay, wait, you said an avulsion of C5. What else is happening? Now you've got to describe the rest of the body. What's happening? The posterior vertebral body, we can't even visualize it properly. It's maybe crushed, compressed. You can use language that if you're not sure, you can use colloquial language, but it's better to use medical language. So you would use, for example, it looks compressed and it looks displaced posteriorly. Now he's gone from here to Wait, what? How's the BP on this patient? Is the patient intubated? What's going on? You know, do you get what I'm saying? Because have you contacted the surgeons? Is there a head injury? What's going on? And you say, no. We've gone to the point where we know it's just a C-spine fracture, you know, for example. You know? So this is how you have to speak the language of the person that you are speaking to, which we will get to now, right? So even when you come to the posterior line, then you can see that there is movement away and things like that. So tell me, at what point are you going to remove the hard collar on this patient? Yeah, very good. You don't remove the hard collar on this patient, right? That most what you would do is probably put your finger through and try and, you know, palpate, you know, to see that, and you would find a step deformity. As you ran your fingers down, that would step out. Okay, so you would see you would feel a step deformity. So it would immediately tell you something's going on. All right. So let's have a look at this one and try and see what was the story with it. So this is called, technically, it's called a flexion teardrop top fracture. Right. So if you remember it, very good. But if you don't, just your description of it. Basically, if you were to tell Dr. Zulu it's a flexion teardrop fracture, he would give you a clap the next morning in the orthopedic meeting, but that's about it. You know, it's, even if you just described it as how it was, and then we arrange for CTs and we arrange for all of that, that's what you actually need to be able to do. All right? So what is this fracture? So this is caused by hyperflexion. So what does hyperflexion mean? This is flexion of the neck. So imagine your chin trying to tuck back in on itself. So your whole head, imagine trying to touch your forehead to your sternum. That's basically what's happening over here, right? So this patient's head has been forced forward quite extensively, right? So imagine the spine, right? I'm just going to put this up for the people on Zoom, right? So that they can see. So here's your spine, okay? So when it flexes, it is flexing around which point? It's not flexing around the top. It's not flexing around the bottom. It's flexing around the middle. So what's going to happen to those middle ones? Exactly what happens here. They get crushed and they get moved out of place, all right? Because it's a column that's collapsing that way. So it's not the top of the column, it's not the bottom of the column, it's the middle of the column that gets crushed. And then the patient comes back up, then all that injury is around that area, all right? Okay, no problem. Just hide this again. So it's what we call a triple column fracture. So you've learned a new word today to describe to Dr. Zulu at 3 in the morning. Dr. Zulu, this is a triple column fracture, unstable. Okay, so when you ask you, what do you mean triple column? You mean the anterior line, middle line, and posterior line, the 3 columns, all right? So the triple column, all right? Extremely unstable. So that means if you were to intubate this patient, you wouldn't be flexing that neck. You have to be very careful, okay? You wouldn't take this patient out of a hard collar. At no point would you take this patient even off the spinal board, because if this neck moves, you might have paralyzed this patient. There's no coming back from it, let's put it that way, right? So up to 50% of patients have spinal cord injuries because you can see, I mean, that's the spinal cord running there. That entire piece of bone has flown into it, right? Most common at C5, which is what we are seeing here, anterior cord syndrome, all right? So what is anterior cord syndrome? Loss of motor, pain, and temperature sensation with preservation of proprioception and fine touch. The reason for that is only the anterior part of the cord. If you can remember that, even I'll give you a clap, because I can never remember anterior and posterior cord syndromes and left and right cord. Both those are hectic things. You have to be very intelligent. You have to be somebody who wants to become a neurologist or neurosurgeon to know that type of stuff, all right? Okay, in any case, we won't really check it. In an emergency department, you're not going to go with something cold, and you're not going to go with something more. Check vibration, check proprioception. This patient's busy dying, intubated. You're not going to pull their hand out. Okay, they hit themselves. Proprioception, you get it, I mean, all right? So this is what CT and MRI looks like, right? So that if you have that opportunity to send the patient for a CT, here you can see it much more clearly, right? Even though you can't see the spinal column on this plane, if you were to come forward and backwards, you would eventually see the injury to the spinal column. And here on the MRI, we can see the injury to the spinal column there, right? So that's the anterior cord that's been affected, all right? So we don't have access to MRIs, but just to show you what it would look like. Okay, very good. All right, so now that you guys are experts at C-spines, let's try another one, all right? So first of all, let's look at the X-ray itself. Let's examine the X-ray. So we've got C1, C2, C3, C4, C5, C6. So is it an adequate X-ray? No, we can't see C7, all right? So hopefully our radiographer would have already given us a swimmer's view, if possible, right? If possible. Sometimes it's not possible. There's a lot of associated injuries, they can't get that, right? But if not, and let's say this patient was walking, talking, we would say, okay, please go back and do a swimmer's view for us. Okay, very good. Then the next thing that we notice, what do you notice about the spine? Even before we look at anything else, what do you notice about it? very straight as compared to how a spine should look like that. All right. Yeah, loss of the normal curvature, loss of normal lordosis or kyphosis, whatever you want to say. The reason for that happening is muscle spasm. All right, so I mentioned this last week as well. I mentioned it today. So you remember we were talking about the corset of muscles. So your body has a built-in heart collar, basically, which is all those muscles. So when you injure your C-spine, they immediately stiffen up. Same thing that happens if you dislocate your patella or you fracture your elbow. Your muscles all tense up. Why do they tense up? They are providing stability to an unstable but necessary section. Okay, so when you see loss of normal curvature, this should alert you. Am I missing something? Is there maybe something here that I haven't seen? Now, of course, it depends on the type of patient that you get as well. Patient is perfectly stable, maybe had a small accident, something like that, and you really go through this. It could just be due to whiplash and things like that, you know. But let's say your patient, for example, can't rotate the head, the BPs are dropping, you can feel a little step. You need to go back and say, am I missing something? Do I need to ask for help? Do I really need to see the C7? Is there something going on? Do I need an open mouth? So just to give you an example, right? So you're 100% right. So let's follow our lines as well, right? So there we have C1, there we have C2, all right? So we follow along, there's our odontoid peg. So when we follow along this column, what do you notice? With the anterior line, very good. What do you see? Very good, so that's an avulsion fracture, all right? And then as we go down, like I say, it's just extremely straight, that's about it. What about here? Is it straight? Is it continuous? Not really, all right? But that may be due to the loss of the normal curvature as well, all right? So then you would go to the middle line, which would also give you a clue, all right? But I'm just mentioning it because you have to keep an eye out for it, all right? You can't just say, I found one thing, yay, I'm going for tea, cigarette break. No, you have to still look through the whole thing, all right? So we go through the posterior line, all right? Or let's say the middle line, sorry. And again, you can see there's that little jump out, okay? So these little jump outs are quite common, especially when patients are in hard collars. It's simply because our neck is not meant to be absolutely straight. But if your patient has symptoms with that, you have to be worried, okay? And then you come to the posterior line, and again, you can see this is actually okay, right? So the main thing that we see is the fracture over there, okay? So what do you think of this fracture now? Stable, unstable? Yeah, it looks relatively stable compared to the last one that we saw. I mean, except for this little piece. So are you taking your patient out of the hard collar? No, because we haven't said exactly what's going on. We still need a CT. We have a fracture. We have something that's going on. We don't know how far the fracture extends. Are there other things that we can't see? Because we're just seeing one little bit of the bone over here. Agreed, all right? So you don't take your patient. That's why I say, basically 99.99999, you will never take your patient out of a hard collar if you suspect something on the C-spine in the emergency department, right? So the first thing you would do is arrange for a CT scan. Okay, you tell the orthopedics as well, things like that, all right? Okay, so if you had to describe this now to Dr., let's pick somebody else, Dr. Kubeka at 3 in the morning. Now you would say, I've got an avulsion fracture of C2. I'm arranging the CT spine for you, all right? CT, C-spine, and I will let you know what's going on, all right? Okay, or ideally they should come and do it, all right? But we know how our doctors are. Okay, so this is an extension avulsion fracture. Okay, which is what we see there. So this is caused by hyperextension. So what happens with hyperextension? I'm just going to put the video. So again, now we've got our neck. Imagine our neck the other way around. Okay, so when our neck bends the other way, what moves? It's more the upper parts, all right? As compared to when it falls forward, it's more the middle part. But when we go backwards, we're actually moving the top part of the neck. So hyperextension means try and touch your occiput to your shoulder blades. That's hyperextension. Sounds painful, huh? Okay, but that's what it is basically, all right? So what happens is as it's getting extended, all those ligaments that are holding the spine in places will also tear. And as they are tearing, they cause avulsions, all right? So that's why you're getting avulsion fracture. Okay, so I just wanted to show that for the people on Zoom, all right? So this is what we call a single column fracture. Okay, right. It's relatively stable, but may become unstable if the neck is extended. So what they're trying to say is that if you're going to intubate the patient, you have to be very careful, all right? Most common at C2, generally treated with a rigid collar and conservative management. Okay, so this is just to teach you some of the vocabulary around this thing. Recording this, so to make sure, oh, yeah, we are. Okay, so let's try another one. So first of all, let's look at just the general, what's the first thing that you notice? Again, even before you start counting and looking at other things, what do you see about the spine? Straight, absolutely straight. Great. Yeah, no, we're going to get to everything. Don't worry. But listen, now the thing is why I say that is because it's very good to just jump and pick out things. But what if you miss something? Again, it's like I say, you picked out one thing. What if you miss something? So be systematic when you look at it. All right. So what bones do we have? C1, C2, C3, C4, C5, C6, and we can see C7. Can even see the inferior. So it's relatively adequate. All right. We would say it's adequate. Then we would look. Now let's look at our anterior, what you call it, line. So let's follow there. And what do you notice? Very good. Okay. Now compare this to the previous one where we were kind of debating whether it's moved or not. This is obviously moved out of place. All right. So this is moved quite far out of place. And then we look at the middle line. And what do we notice again? It's moved out. Agreed. So is our spinal cord at risk? Yeah, it's highly at risk, isn't it? Because the spinal cord is essentially there, and then getting pushed back and then carrying on there. Okay. And then if we look at the posterior line, and you see again, it pops backwards this way, all right, as these are moved out of place. So any idea what's going on here? Because it's not a fracture. Yeah, displacement, another word for displacement. Dislocation, all right. What generally dislocates in the spine? We have facets, all right. So we have two facets on either side, all right? So the facets, how they work, let me just put this up again. So you have your superior vertebral body and your inferior vertebral body. So the inferior one has sort of two pegs that point out that way. Those are its facets, its superior facet. And the top one has two pegs that sit out that way. So what happens is the pegs actually lock into one another. Those are the facets. So you have two, okay? So let's say one dislocates, just this side, not this side, all right? What will happen is the spine can now, the vertebral body can move, but all it can do is rotate, okay? Because the other one's still holding it in place. What will happen is both come out. It can just slap, all right? Just remember that, okay? So in this case, we have a facet dislocation, okay? This one in particular is a unilateral facet dislocation, okay? The reason why we say that, it has to do with the amount that it moves. So the less that it moves, the greater the chance it's a unilateral. The reason being, it's still being held by the other facet, okay? So we generally say, if the movement is less than 50% of the superior body compared to the inferior body. In our case, if there's any movement, we just call it a facet dislocation. Call it a unilateral, very good. Then the patient goes for a CT, turns out it was a bilateral. It doesn't make a difference to our lives. We treat the patient exactly the same. What we are going to do is that we are going to do a CT scan. We are going to involve orthopedics. They are going to take over. We're going to look for neurogenic shock, keep the patient in a hard collar, all those things that we've been talking about, right? So these are generally stable, but they can become unstable simply because the other one can dislocate as well if the neck is being allowed to move freely, all right? So what would you do? Place the patient in a rigid collar, requires treatment with traction, can cause a neurological deficit depending on how much they move, okay, right? So let's look at that on a CT scan, all right? So that's what it looks like on a CT, okay. All right, let's try another one. So first, let's have a look at the X-ray itself, right? C1, C2, C3, C4, C5. So it's obviously an inadequate X-ray, right? We would ask for a swimmer's view if possible, although in this patient, I wouldn't move them anyway, but I'm just using it as an example, right? And then again, we notice the straightness of the spine with any sort of injury. Now what's happening this time when we follow the anterior line, C1, C2, C3, C4, boom, entire spine moved out of space. Come to the middle line, wow, that's like right now. And look at C, what is this? C1, C2, C3, C4, C5, and C6. What can you notice there? There's almost like no connection between the two. C6 seems to be pointing downwards. All right, so what's happened here? What do you think? Well, because there's no fractures. So this is also a dislocation. But in this case, with the amount of movement, what do you think? Bilateral facet dislocation. Do you think it's stable or unstable? Highly unstable, yeah, because this can move. I mean, this can move completely out. Your patient can basically decapitate themselves. Right? And your spinal cord, under threat, not under threat? Extremely under threat. Okay, so these types of patients you've got to be worried about. Okay, so that's a bilateral facet dislocation. So they occur after extreme neck flexion and anterior subluxation. All right. So basically what they're saying is that the neck moves, it flexes forward, and then basically the facets come out of their grooves from one another. All right. Unstable disc herniation can also occur, but you won't see that on or what you may call it on an X-ray, not even on a CT, but more on an MRI. All right. Careful neurological examination is imperative. 75% of the patients will have this. All right. Yeah. So this is a closed reduction, right? Surgical stabilization. So these ones here are distinguished by anterolisthesis of 50% or greater. Anterolisthesis is movement, right? So it's saying 50% of the vertebral body is displaced from the other one, all right? And lack of rotational deformity. So what is rotational deformity? Again, when you would generally get an AP view as well, right? So on the AP view, we normally look at our spinous processes and we look at them. So with a unilateral dislocation, the spinous process would be out of alignment. But with the bilateral, it doesn't move out of alignment because it's just sliding back and forth. But with the unilateral, it's rotating. Okay. All right. CT is important, of course. Okay. So now you have to phone Dr. Bijli. Yeah, I like all those laughs. Yeah, just put it back in place. Yeah, just sort it out. Yeah. Agreed. Then you have to phone me. I have to phone Dr. Ketsi. Dr. Ketsi has to phone him. But you understand now, you're going to tell him this is a bilateral facet dislocation. Patient has got evidence of neurological deficit. Which is the neurological deficit? I've excluded other injuries. Patient is going for a CT. You need to come in and see this patient. Okay. So these are not, you must remember, these are not injuries you're going to see every week. You get 1 or 2 of these a year. I'm talking about in total, all these severe injuries. But when they do come, they're bad, right? So there's the CT of the patient, right? So you can see how bad it is, right? And you can see, even though we couldn't see C6 properly, yeah, it's fine. But it tells you that if you don't have an adequate X-ray, you can't see what's happening, all right? So that's why you need an adequate X-ray. Okay, and that's the last one we're going to go through now. So it's not really an X-ray, but what's going on there? It's a complete transection, right? Complete transection of the spinal cord, okay? So, I mean, you can see, I mean, this was a terrible force that was applied to this patient, all right? And causes it's essentially almost like an internal decapitation, right? You can follow the spinal cord just there. So you can see what's happened to it there, all right? So let's look at this. This is just going to take, so this is a complete transection. So these do happen in C-spine, T-spine, L-spine, they all happen, all right? So it's the most severe form of spinal cord injury, all right? Because the spinal cord is basically torn in half, all right? It can be partial, complete, right? It's typically noted at the level of the vertebral fractures or dislocations on imaging, where the spine is compromised, okay? So what are the clinical implications, all right? Spinal cord transection usually occurs secondary to vertebral fractures or dislocations after trauma, all right? Can also follow penetrating injuries such as gunshot wounds or stab wounds, okay? Refers to complete loss of motor, you know, things like that. Commonly occurs in patients with multiple sclerosis. Okay, all right. I just want to get to the past. Right. So below the level of the injury, there's loss of reflexes and sensation. All right. So this is now more to talk about what happens after that. Okay, but we're not too worried about that for us. So the Pearl spinal cord transection is far less common than spinal cord contusion and compression, which also occurs. Non-traumatic vertebral dislocation can occur in patients with rheumatoid arthritis. Okay, so just remember. So this is something I hope you never have to see. And it's the thing that you do have to see. It's not the type of thing you manage on your own. Okay, because these things are normally associated with other injuries. It's very unlikely. It's just purely orthopedic. You know, majority of the time there are other injuries such as gunshots, stab wounds, severe facial injuries, brain trauma, things like that. And a lot of these patients don't make it, okay? So this was just now to give us an idea of some other fractures that we have a look at. That's the end of it. We're still gonna have another one next week. We're gonna look at more fractures. That's just a joke to finish off, all right? So for those with Asian parents, we know what it's like, all right? But any questions, anything that you want to know, anything that seems confusing or worrying or anything like that? Okay, so generally C-spines, just as long as we have a system of looking at it, all right? So for those of you who went with us last week, have a look at last week. So we talk about that system. I'm going into more detail of how you should look into it. But just as long as you have a system, you won't miss your injuries. And the thing is, at the end of the day, and remember, all of these lectures are based on an emergency department point of view. from the emergency department point of view, most important is that you don't miss the fracture. You don't have to take this patient to discharge. Your only job is to make sure that if there is something suspected, that it is investigated, that you can treat it, and you don't cause more harm. Okay. So, I mean, you know, a lot of you guys, once like you finish your internship, ComServe, things like that, you'll end up maybe at smaller hospitals and things like that, but you don't really have seniors to look at and help you and things like that. You've got to know these things. You know, you don't necessarily have to know all the signs of endocarditis, but you need to know how to look at a C-spine injury. Do you get what I mean? You don't necessarily have to be able to diagnose a AAA on every patient that comes with abdominal pain, but at least you must be able to look at an L spine and see what's going on. So these are important things too. All right. Okay. If there's no questions, then we'll just end it there. If you have questions, you can always ask me later. Okay. All right. Thanks. Bye.